Well, hello, everybody. Good afternoon, good morning, depending on where you are in the country. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'd like to welcome you to today's live webinar hosted by Roji Health Intelligence. And today's session is the first in a three-part series titled How the CMS National Quality Strategy Can Guide Your Value-Based Care Journey. And today's session is part one, which is the value-based primary care means more than measuring total cost of care. Again, we're going to be doing three of these, and towards the end, we'll make sure you have information about how to sign up for the next two. But a couple items of note before we get started, just some housekeeping items. First of all, this is a traditional webinar format, so everybody has joined today in listen-only mode, so you don't need to worry about turning off your mic or off your camera or anything like that. Don't worry about that. We can't see you or hear you, but as I always say, we do want to hear from you. So we're going to have a time for some Q&A towards the end. And at any point during the presentation, if you have a question, if you have something that you want to ask our speaker today, who I'll introduce momentarily, go ahead and drop that question into the module. You'll have a little area where you can ask questions there. And we're going to get to as many as we can today. If we don't get to yours for some reason, don't worry. Someone will reach out to via email afterwards and make sure that your question is answered. And then finally, the session today is being recorded. So what's going to happen is when we're done, you'll receive an email that will have a link to the recording as well as to where you can download the slides from today's session. And there may be some other information too about also how to register for the next two sessions in the series. So finally, without further ado, I would like to introduce Mr. Dave Halpert. He is the Chief of Client Team with Roji Health Intelligence. I've known Dave for a long time. He's a great presenter, so I think you guys will really enjoy the session today. So welcome, Dave.
Thank you very much, Garrett. That's quite an intro. I will do my best to live up to it. As Garrett mentioned, this is the first of three presentations in which we're going to explain how the National Quality Strategy from CMS is going to guide you on your value-based care journey. So we're going to start today talking about primary care, and the next one we're going to move to rolling up specialty care into your value-based care journey, and then finally how to maintain your competitive edge once you have gone through all of this. So a little bit about us. We're a services and technology company. We are based in Chicago, and we help our clients to develop and implement their value-based care strategy, improving outcomes, improving efficiency. We've developed tools that identify at-risk patients with specific and targeted interventions, and we are a CMS qualified registry for QPP, Quality Payment Program reporting. That goes for both the MIPS program and also the APM performance pathway, the APP. And we report both MIPS CQMs, Medicare CQMs, and ECQMs. I suppose it's three now, not two. MIPS CQMs, Medicare CQMs, and ECQMs. Our episodes module, we've developed that so that you can look at cost variations and cost drivers based on the information that you can actually control and is clinically relevant, so that you are able to deploy interventions that make sense, that address total cost of care, and are able to do more than just see, I suppose, dollars and cents. It is much easier to be able to tell whether or not your interventions are having the effect that they desire. So you are in the right place if you are an ACO that's looking at evaluating affordability and looking to enhance savings. If you are a medical group that's interested in maintaining consistent revenues or improving revenues, any organization that's on the path to risk, considering value-based payments, like population-based payments, and this is whether or not you're looking at that in terms of Medicare or Medicaid, or it can be any private health plan. There are plenty of them out there that have their own value-based care initiatives. And so if you are in that market, again, you are in the right place. And then finally, health systems, medical groups, negotiating contracts with risk features. So these are all of the reasons that you may want to be paying attention here today. So here's what we're going to talk about. We're going to talk about the turning point happened sort of right as we were learning a lot of lessons from the pandemic, and that was the national quality strategy. The strategic refresh is what they branded it, and then we'll touch on the current strategy. It was there was an updated piece called Quality in Motion, and it was just released about 2 months ago. And we'll talk about how they provide the underpinnings for primary care in CMMI models. CMMI is the CMS Innovation Center. And finally, we will talk about within those models, what can you learn from them, even if you don't necessarily participate, that can help your organization to have a successful value-based care journey. So before we get into that, let's learn a little about you all. Which of these best describes your value-based care strategy? So we're looking for the best answer here. Choice A, our focus is on care coordination for patients with chronic conditions. Choice B, we're looking at feedback reports from CMS, trying to identify patterns related to high cost and poor outcomes. C, we're evaluating which value-based care model is our best option. We're going to participate in something. We just don't know what yet. And finally, choice D, we are getting by on getting by. We are not involved in anything right now, and we are going to see how long we can ride the fee-for-service train. Give you all a few minutes to...
Yeah. We've got the poll up on your screen now. So, and again, this is a choose one. By the way, this is anonymous. So we're going to share the results here so you can kind of see where you stack among your colleagues here in a moment. We've still got the results coming in, but go ahead and choose one that best applies. And Dave, are you able to see on your screen these coming in?
I can.
Okay, great. It's always a little different with each speaker. So we still got a couple coming in. So Dave, whenever you want to shut it down, you just let me know and I'll do it.
Okay, I'll give it another, still looks like we got a few people voting here, so I'll give it another 30 seconds or so. All right, it looks like we're about leveling off, maybe a 5 count.
Sure. Oh boy,
they
just keep
well,
rolling
hold
in.
on. We got apparently that got everybody going. That's how it goes.
Just light a little
All
fire.
right, now let's do our 5 count.
Okay. So I'm going to go ahead and shut it down in 5, 4, 3. It's going to be a long 5 count. 2 and 1. And I'm going to go ahead and shut this down and I will show you the results here. All right. Dave, were you able to see that?
I can. We've got about 50% of our respondents looking focused on care coordination for patients with chronic conditions. So this is definitely the show for you. Looking at CMS reports for patterns of high cost coming in at about 30%. Evaluating which model is our best option, 11%, and then 9% getting by on getting by. That's all right. These are all good to know. It's always interesting to see where people stand, and so that's very interesting to hear. All right, so let's get into it now. We are going to talk about how it started, the strategic refresh. It came out in 2021. It was an action plan released by the CMS Innovation Center. Briefly, the Innovation Center was created under the ACA as the entity for testing new models that are going to move providers away from fee-for-service. And that strategic refresh contained lessons learned from the first decade of models, and it was based on more than 50 models tested between 2010 and 2020. And it also had goals for the next decade of programs and overall transformation. And the strategic objectives of that strategic refresh drive accountable care. So in the, if any of you have been to any CMS webinars, they've been describing that their goal is to have 100% of people in accountable care relationships with their providers, or 100% of people in traditional Medicare in accountable care relationships by 2030. That is where this first came from. Advancing health equity, CMS wants to see, and others as well, want to see more reporting of demographic data, including, particularly including social determinants of health data, and including all populations. And that's, again, what is partially behind the push for all patient reporting. Also supporting innovation, looking at patient-reported outcome measures, surveys, an emphasis on shared decision-making and care coordination. Affordability, there are a lot of people who have to forego care or make very difficult choices about when they should receive care because the cost is simply too high, or there may be other barriers in place, barriers like transportation, or even accessibility. And then finally, to partner to achieve system transformation. So looking at multi-payer initiatives and over a longer period of time. And the longer period of time comes from one of the lessons learned. And so that's the next thing that they talked about is, and we saw this during the pandemic. It was very revealing that health equity had not been previously addressed in program development. One of the first things that we saw during the pandemic was who was affected more frequently. Were people where there was where the idea of sort of social distancing was not a possibility. So nursing homes, very crowded places. It was just not something that could not be handled. So health equity was not addressed in program development, and that became visible during the pandemic. The models were too complex. Anyone in this sort of realm understood that it was a challenge to figure out, particularly for ACOs, who was sharing in which pot of dollars. It was impossible to tell where that money was coming from, where it was going, what was coming at the expense of something else. There was also an understanding, finally, that transformation and willingness to accept risk can't occur without investment. And so, as we talk about some of the programs that are happening currently, that there is a feature for upfront investment from CMS. Again, we've seen that in the ACO world with advanced incentive payments, and other programs sort of follow suit. The other issue that they raised was that participation was inconsistent, and so it led to a selection bias. You're not going to necessarily sign up for a program unless you truly believe that you're going to do well in it. And so what happens then is that the people who do well, it gives the program a sense of proving its worth, when in reality it is not necessarily one that could roll out successfully to the greater population. Financial benchmarks, and this ties in slightly with complexity of models. The benchmarks were opaquely calculated, and what that did was it eroded trust of all of those who were participating in the program itself. So if you didn't necessarily believe that there was any value in the benchmark that had been set for you, where's the incentive to participate if it is not something that you believe is calculated correctly and that you will be able to match? And then finally, the most important piece is that lasting transformation is necessary to prevent backsliding. And so as we talk about some of these models, there are a couple of them in particular that have been released more recently. They are 10-year models, and so there is a much longer track in understanding that this is going to take time to move away from fee-for-service into a value-based care setting. So that was how it started. How it is going. We are in the national quality strategy now. And again, it was the National Quality Strategy was enacted in 2022, and the latest update came just a couple months ago in 2024. It's called Quality in Motion. Very interesting document. And the goal here is to improve quality and safety for all patients, particularly for patients within underserved communities. It's the way to look at this document is an update to the strategic refresh based in particular on a lot of the lessons we learned during the pandemic. In addition to opening our eyes to inequity in care, it also was quite illuminating to see what happens when there is not a constant revenue stream. That fee for service, when nobody is coming into the office, can, in the same way that it did for restaurants, it was very difficult for providers to keep their practices open. The other piece about the national quality strategy is that it is intended to be person-centric. They are getting away from the traditional Medicare post 65 group of patients. They want this to be something that goes from prenatal care all the way through the end of life. The national quality strategy, again, the aim is improving healthcare across the country by doing a few things. First and foremost, measuring quality. That's something that in the CMS Quality Conference actually released shortly, right around the same time the Quality in Motion paper came out. It's when there was a big discussion about how quality measurement is going to be more important. I'll talk a little more about that shortly. The development of more value-based programs and models, making sure that they are all transparent. So when you as a patient or a provider are able to see the results, understand what they mean, and use that to make informed choices. Implementing safety standards, and then finally providing technical support to facilitate continuous improvement. Again, that's something new that CMS has been doing, is providing technical support. And so this national quality strategy has goals. Each of them has two areas. So we're looking at interoperability and scientific advancement, safety and resiliency, outcomes and alignment, and equity and engagement. And going through each of these very briefly, when we talk about outcomes, we're looking at high priority issues and benchmark outcome measures. So what are high priority issues? They're things like that need immediate attention. So the best example of that right now is maternal health. There is going to be a program coming shortly where there are birthing friendly designations for certain hospitals to address the fact that in the United States, we have a true crisis in maternal health. When we're looking at alignment, we're talking about trying to get away from what we had before, where nobody knew really which program they were participating in, other than some of them. There were checks, but it wasn't always clear what money was coming from where. So approaches that align across programs with a foundation of universal quality measures. In terms of equity, the targeting of underserved populations to ensure that care is received everywhere, specifically to get more information on that by improving data collection, especially as it relates to social determinants of health. The use of diagnosis codes for social determinants of health is a big thing. And then finally, engagement, getting input from the patients in the community, public reporting of results in program participation. And that goes right into safety, where you're looking at transparency and comparisons, the ideal being getting to that place of zero preventable harm and incentivizing improvements. Resiliency is to address staffing and infrastructure. What I was saying before about what the pandemic did to practices trying to keep their doors open, what we're seeing now in terms of staffing shortages that are being felt across the industry. Another piece of that is supporting providers in emergencies. So as it relates to climate-based events, man-made or nature-made issues that are coming down to provide support to providers. And then finally, this last bit is interoperability and scientific advancement. So interoperability means standardizing data exchanges, moving to digital quality measures. Those are going to be the next phase of quality measurement. And that's why, and we'll talk about this in a future presentation, why all your eggs should not go in the ECQM basket, because digital quality measures are going to change a little about how data is collected and how it is reported. And then finally, scientific advancement. So more data for research, being able to evaluate new tools like artificial intelligence tools. So those are the underpinnings for the models that CMMI is releasing. And so we're going to talk about now how about they weave those objectives into those healthcare transformation models. First, let's talk a little about the CMS Innovation Center. What is it? It is it was established under the ACA, and its job is to create pilot programs that are aimed at getting providers away from fee-for-service and into value-based care. In the last decade, they've tested more than 50 models. Some of them are specialty models, some of them are primary care models, and some are mandatory, some are voluntary. It depends on the model and the target. A model can be expanded if it does one of three things. If it lowers cost while retaining a quality standard the same as before, that can mean the model is rolled out. If there is higher quality but similar cost, that will also qualify as success. And then finally, the obvious ideal, lower costs and higher quality. And it's very interesting, at this point, no model has been expanded on the basis of quality. The ones that have been expanded have been on the basis of lowering costs. And so one of the things that was mentioned in repeated presentations from CMS and some of the other presenters at the CMS National Quality Conference earlier this spring is that is going to change. There is going to be model expansion on the basis of quality, both quality reporting and measurement of utilization. And so those are things to keep on your radar here. And so those of you who are looking at managing chronic conditions for patients and keeping them out of those high cost areas, that is going to be something that is very useful. That is your end goal. All right, so here's the timeline for there are 5 big primary care focused models over the last couple of years that are in play right now. The first came out in 2021. That's the ACO REACH model, and then the primary care first, and what was just released very recently, ACO Primary Care Flex, PC Flex, and then finally, the last two, which are 10-year models, as you can see, starting this year and going all the way through 2034, the AHEAD model and then the Making Care Primary model. So I want to touch on these very briefly so that we can see what makes them tick, and then we'll get into how the key features of these programs can be utilized so that your model for your organization can be successful. So let's start with ACO REACH. This was the evolution of the global and direct contracting models. So following the pandemic, the Innovation Center realized that those previously planned models were missing some important pieces, particularly relate to health equity. And so that was the big difference between ACO REACH and the global and direct models. Both had upfront payments in the form of capitation, both for primary care only or total. That was the difference between global and direct. But the ACO REACH model does a lot more in terms of prioritizing health equity through benchmark adjustments. There are outcome-driven quality measures that are based on claims, and also scores total cost. It is voluntary, and it was intended to increase new ACO formation. Again, that is the goal from CMS, is to get everybody in an accountable care relationship with their provider by 2030. And so their path to that is to have new ACOs join, particularly in, and not be afraid to join even if they serve underserved communities. The next model here is primary care first. It came out of the CPC Plus model, and some of you, I'm sure, here were involved in that CPC Plus model, and it was an important one because it was the first one that required all patient reporting through ECQMs. It was a Medicare program that required that all patient reporting, and similar to MIPS in that fashion, but it was the first CMMI model where that was a requirement. Primary care first continues to on that front, and it actually goes beyond ECQMs. There's also the requirement to report on whether or not patients have an advance directive, and if there is a surrogate decision maker that's in the record that is not an ECQM, and that's something that the primary care first participants must do. The overall goal here, though, is to strengthen the relationship between individual clinicians and patients. So again, upfront population-based payments plus flat fee for visit payments. So yes, there is a fee for service component to it. However, there is also a value-based component as well, and that is the calculation of total costs along with the quality reporting and the claims-based outcome measures. So it is multi-payer. It includes patient or quality reporting on all patients here. So yes, CMS is only able to calculate claim-based outcome measure results and utilization for Medicare patients, but those quality measures are submitted in the aggregate to CMS. So there is no patient level data in there, and so they are scoring based on the inclusion of all patients, regardless of health plan or even patients who self-pay. Some of the longer models here, we're looking at making care primary. As PCF phases out, making care primary is the one that is going to sort of fill its shoes. The participants move through 3 tracks, starting from the advancing fee for service all the way to transformation and population-based payments. It's sort of the equivalent of I'm a runner, so the first thing I thought of when I saw this model was the running store by me has a from couch to 5K program for people who are still who are just beginning this journey, and with the goal of taking them all the way through a successful race. And that's sort of the same model that making care primary is doing too. So the first piece is to set up the infrastructure where you're looking at reviewing your own data, stratifying the risks of your patients. You're still remaining on a fee-for-service track, but you've got some CMS support now to move beyond that. Track 2 is where it's referred to as advancing primary care. So you've got partnerships with community organizations, behavioral health screenings, and a transition from fee-for-service to population-based payment. And that last track is the continuation of 1 and 2. You're going to move to full population-based payments. You're going to strengthen those partnerships to organizations within the community and continue to do those behavioral health screenings and get patients into relationships with behavioral health providers that need them. It's a full 10-year program. And those community partnerships, those 2 pieces together, indicate that CMS understands that there is only so much, regardless of how talented a provider, how caring a provider may be, there are certain things that are going to need support, either from caregivers and families through making connections with the community at large. And that continues here with the AHEAD model. It's an 11-year model, and it is run by states, which distinguish it a little bit, but it's the same sort of idea where looking at partnerships in the community. The state must ensure geographic coverage, or excuse me, coverage in all geographic areas within the state itself. There are enhanced payments to providers that are caring for vulnerable populations. Again, there is that recognition that when you have vulnerable populations, there needs to be some sort of financial incentive to make that work. Otherwise, it's just not feasible. Everyone only has so many resources, whether those resources are capital, time. There's only so much that anyone can do, and so those upfront payments help people to be able to staff up, to increase the power of their technical infrastructure, so that all patients can get the care that they deserve. And then the last piece of this, again, going similar to the Making Care Primary model, is the collection of SDOH data and health-related social needs data that enable providers to see what supports patients may need beyond what the provider may see in the office. And the last one here, the just released ACO-PC Flex. It is a 5-year voluntary model test. It is occurring within an existing low revenue ACO. So it's similar to the AHEAD model. It's similar to Making Care Primary, but what distinguishes this one is that we're focusing on program alignment. So CMS recognizes that those upfront payments are a huge enticement to people who are getting into this value-based care transition away from fee-for-service, but they don't want to sap participation away from ACOs. So instead of reducing the ACO market, the solution here is to allow the low revenue ACOs to get in on the action, getting prospective payment options for primary care, advanced shared savings patients. There is a limited fee-for-service patients to fund primary care, but there's also a greater push to enhance health equity by including rural health clinics and FQHCs. So what they're trying to do here is they're trying to incentivize the creation of new ACOs in areas where people traditionally may have avoided that route because they didn't think that there was a way for them to be successful. So in here, quality and cost are measured, not surprisingly, the same way that they are in any other ACO. It's through the quality reporting module, which is going to be through the APP in very short order, and then also cost and utilization metrics. So those are the programs that I really wanted to highlight as they relate to primary care and show you where the Innovation Center is heading. So what we need to do now is talk about how some of these models, they all have the same underlying pan program models, or excuse me, pan program features, and they are going to help guide you into your program. So there are 4 big ones that I wanted to cover today, and they are investing in infrastructure, enhancing data collection to identify disparities, all patient quality reporting, and cost and utilization measurement, and then finally multi-payer alignment. They sort of all go together. They don't need to be linear. You can begin to, for example, improve your data collection techniques now while you're in the process of investing in infrastructure and interoperability between your practices. The most important thing when you're investing in infrastructure is that it is done wisely. There's no correlation between spending big and getting big. We've seen clients that have spent $100 million on EHR implementation only to, their words, blow it up after 5 years because the implementation itself was so bad, and so they had to go through a second implementation process. Comparing that to some of our clients who have spent considerably less money and gotten considerably more in terms of being able to track a single patient across the continuum of care and be successful in multiple programs simultaneously. So the important thing to remember is that, first of all, no two organizations are identical. Everybody's got different patient populations. Everyone's organization has different priorities, technical, financial, staffing resources. The cookie cutter approach looks wonderful on paper, but for an investment to make any sense, it's got to perform well in the real world. And so within that, the data aggregation piece is going to be a must-have for you. You cannot have a value-based care program that is successful unless you are able to track a patient across the continuum of care. And that means having total data aggregation. If you aren't able to track disparate sources of data, you cannot create targeted interventions because your data is missing too much. You're not going to know, for example, that a patient has a behavioral health diagnosis and has or has not received care from a behavioral health professional. It's the same reason why, even though QRDA files, quality reporting document architecture files, they are helpful for some quality reporting programs, they can't be your standalone solution because they are only going to have values that are limited to patients who have both triggered quality measures and the results that are associated with those. There is too much that is going to be important to overall costs and quality that go beyond ECQMs. And so you need to be able to get beyond that into a more comprehensive data aggregation approach. Start early. There are going to be data-related obstacles. I do happen to love this slide, and I learned my lesson this year. I got my cards 2 days before Mother's Day, before the rack looked like this. Comprehensive data requires education and standardization, and so it's not going to be a turnkey process. There are going to be some practices in EHRs that are easier than others, and getting feedback and some early successes are going to help create program champions. There's nothing that is going to move your program faster to help it build up like those program champions where you start getting some word of mouth. It really is something that takes sort of a grassroots involvement to make it work. A top-down approach is sure you can start that way, but it's only going to carry you so far. And so getting these early successes in and building momentum is going to be and is a surprisingly important piece to that. The next piece that we want to talk about is improved data collection and how that is going to update some of what you're able to do for your patients. So if you can look at these three things in particular, health-related social needs and social determinants of health, improved diagnosis, coding, and behavioral health, these are going to be absolutely huge. And there are several reasons for this, and they can be done in a way that is not overly burdensome for you as well. So if we're looking at collecting social determinants of health data, health-related social needs data, these are things where you can identify specific disparities in care and understand which patients may benefit from certain community resources. You as the providers are not going to be able to deliver all of this to the patients, but by connecting them with those resources, you are going to see healthier patients, happier patients, and lower costs. Diagnosis coding is something that you can control. It's one of the things that Medicare looks at and other health plans look at when they are risk adjusting. They're looking at your diagnosis coding because that's what they see. Everyone says that they have sicker patients than everybody else, but if you are coding, let's say a patient with type 2 diabetes, that E11.9, that type 2 sort of plain, but that patient has has either comorbidities or has seen complications related to, let's say, their eyes, their kidneys, something along those lines, those are not seen by anyone who is looking at risk adjustment. So they're looking at those patients in the same way that they would someone who is well controlled. And so having that data is better for you in terms of recognizing the disease progression and being able to intervene. And it also it also is going to enable those health plans to provide more realistic benchmarks for you. So you may think that your patients are sicker, but unless that is visible to the people who are doing the benchmarking, it's not something that will be quantified within your benchmark. And then the last one that I wanted to focus on here is behavioral health. Um, Obviously, a well-documented correlation between patients with behavioral health diagnosis and chronic condition outcomes. And so if you are able to identify patients with emergency department inpatient utilization and no behavioral health visits, that's going to be a huge win for you. And obviously, behavioral health is in short supply, but there are abilities to connect patients with virtual behavioral health resources. And that is something that came out of the pandemic that has been a real benefit to a lot of patients that otherwise did not have the ability to get to services that they needed. Give you some idea of what this means. So if we were looking at aggregating data to create a proactive population health intervention, on the lower right-hand side here, we can look at patients who have diabetes, and this is something that we look at patients who have persistent poor control. They have been sort of hovering in those poor intermediate outcome ranges, and they may be on the cusp of having something much larger happen to them. You want to be able to get to them before that happens. And so with a full set of aggregated data, you can get into the weeds a little bit more and understand which specific interventions are going to help a group of patients. So you can't just go in with the idea of lowering A1C, for example. We need to see why that is. Is it that that the patients are obese and there hasn't been a nutrition or dietitian visit? Or is it that there's been a behavioral health diagnosis and no behavioral health visit? Is it something like that where there is an issue of the care, the patient is not seeing the providers that they probably should be? Is it that there is an issue with the medication where there hasn't been any new medication that's been tried? So one intervention for lowering A1C is not going to be the same thing that works for everybody. And so being able to see the specifics of your persistently poor controlled population is going to make the difference between being able to see the results of your actions and just sort of attempting without seeing anything for your efforts. So the enhanced data collection cycle looks like this. You start by collecting more information to illuminate those disparities. Then you create those interventions that improve those intermediate outcomes and then potentially keep your patients out of the hospital. But they have to be the ones that work for your patients. There are going to be patients that for one group, they may be more related to patient care and referrals. For another group, they may be related to aspects like the care received itself, what medications patients are taking, etc. And it may be something where the patient is not taking medications because there is a cost associated with it. The provider may not know until we're collecting the information about that. Once you know that, you can measure the effects of those interventions and adjust on data-driven outcomes. So you can actually see, we're doing this, is it working or not? It is great to be able to say that you are creating interventions, you've hired care coordinators, but unless you are able to see truly that you have made improvements, it's not something that you're going to see as it relates to your overall costs and your overall patient's health. And then once you've done that, repeat. All of the programs here have quality measurement, and so there's going to be a much greater emphasis on demonstrating quality, and that comes from two facets. That comes from quality measurement and those administrative claims or administrative claims measures. So patients who have a chronic condition and have been admitted. We'll start with quality reporting. The most important thing to do is remember that your goal should be to report on all patients. And the APM performance pathway is a great way to start. And I want to emphasize start. We have to start somewhere. It's a great primary care set. A1C control for patients with diabetes, blood pressure control for patients with hypertension, and then screening for depression and follow-up. We've talked about the advantages of the all-patient measures. You can ensure that you have one high standard of care. You're demonstrating excellence when contracting with any health plan. Ideally, you will move beyond these measures, but again, there is it can be detrimental to try to take on too much too fast. This is a great place to start, and it also has that benefit of getting some buy-in in your program because these are the same measures that you will be reporting. Once you have started using those quality measures, the best thing to do is to use them as they are intended. They don't need to necessarily be a mechanism of punishment. They can illuminate opportunities. So are patients with high A1Cs, are their treatment plans changing? For patients with high blood pressure, are those blood pressures really high, or are they being taken improperly? That's something that we have actually seen out in the field, is looking at specific variations between certain providers and others, and the recognition from the people on site that the providers that have patients with higher blood pressures have had recently hired nurses, and those nurses had not been educated on the proper blood pressure measurement technique, meaning both feet flat on the ground, back supported, etc. And so those blood pressure values were artificially high. So by chasing down patients trying to lower blood pressures, do they really need their blood pressures lowered, or is there something that we might be able to do just to ensure that our results are as they should? And so this is something here where we're looking at patients, again, who have, these are one of those populations for targeted intervention, and you can look to see whether or not your interventions are having an effect on them over time. You can do the same thing for measuring utilization by practice and provider, looking at patterns and comorbidities and persistent poor control. So are there providers who have patients who have more hospitalizations? And if so, remember, that does not mean that they are necessarily a high cost or a quote unquote bad provider. They may be seeing patients that need much more support. And so if you're looking at a value-based care incentive and how to distribute some of the upfront payments that you are receiving, there are going to be people who may need more support than others just based on where they are located and the patients that they see. And then finally, you can leverage that all-patient quality measurement to improve population health itself. That quality reporting is that entry-level benefit. The best thing to do is by capitalizing on your investment. You can incorporate other health plans. That national quality strategy I had mentioned was intended to drive change throughout the system as a whole. There's that push for a universal foundation of measures that different health plans are going to be looking at, ensuring that the same quality measures are tracking the same cost and the same utilization. So that that corollary benefit to all patient utilization is that whatever health plan you're participating with, you're going to be able to be successful there. And then this last one here I've got before our questions and answers is looking at variations in outcomes by provider, and you being able to look at this by both provider, by health plan, or by practice. These are all critical in identifying those disparities. And again, they do not necessarily mean that one provider is quote unquote better than another provider, but it does help you identify variation and gives you a little bit of insight in how to create an intervention that is going to provide real change for your patients, as opposed to something very standard where the organization is simply trying to change an overall control value, because that's not going to be sufficient in the long run or even the short run necessarily. So that was a lot that I have covered, and I am ready for questions. So Garrett, I will turn it back over to you.
All right. Thank you so much, Dave. Obviously, everybody, we've covered a lot of material here today, so your head may be kind of spinning around. You may not even know what to ask. But if you have a question, go ahead and drop that into the question module now, and we're going to get to as many of them as we can during the time today. And if you figure out your question later on, even as we're wrapping up, go ahead and drop it in there. Someone will get back to you by email if we're not able to get to yours today. And by the way, I saw a couple folks had mentioned they I guess the slides weren't advancing at one point, and I think I didn't see that on our end, so that may be some sort of network issue. I know there's some crazy weather going on around the state, so that can affect it. So apologies for that. But the recording will have all of the presentation there. So without further ado, let's go into the questions here. And okay, let's see here. Question thread. All right. So first question is this: with so much focus on interoperability, is quality reporting going to remain relevant?
Yes, yes, it will. And that goes into those digital quality measures that I was referring to earlier. Quality reporting was something that was raised at that national the quality conference from CMS, is how they want to see more programs moving forward. And as it relates to digital quality measures, they are going to be looking at information that goes beyond what we see in the ECQM world. They're going to be a lot more survey, patient-reported outcome measure, or survey measures, patient-reported outcome measures, coming from sources that we may not think about now, like patients and wearables. And so all of those disparate sources are going to be able to, they're going to need to be aggregated and transformed into quality measures that may look a little different than the ones we see today. So yes, definitely quality reporting is something that is going to remain critical even as interoperability advances.
Wonderful. Okay, next question here is these upfront payments sound a lot like capitation. Am I understanding that correctly?
Yes, indeed. It is sort of what's old is new. There are some changes this time, as there are also some of these programs do involve additional payments for fee-for-service, like in-office visits. But yes, that these are very, very similar to capitation, arose by another name, you may say.
Wonderful. Okay, next question here is, can we report through the app even if we have practices who don't have certified EHR technology or can't
Yes,
produce
you can. You
patient
can.
report?
The APP allows reporting through. There are different types of measures that you can report. You can report on Medicare CQMs or MIPS CQMs. Both of those measure types allow what we'll call manual intervention. It is not where everything is calculated by the EHRs and shunted off to whoever is scoring the measure um, for results. With the MIPS and Medicare CQMs, you have the ability to find alternate methods of getting the quality measure results from your practices into your overall measures engine.
Great. And apologies if this is repetitive at all, but this next question came in and says, did I understand correctly that your product will submit MIPS measurements as well as all the other analysis that you were going through?
Yes, yes, that's correct. We all of everything else plus the MIPS quality reporting, APP quality reporting for APMs, that is part of our profile.
Okay. Let's see. Next question here. the benchmarks are a problem. The final reconciliation versus quarterly business reviews were significantly different. Was this a pandemic problem or a risk adjustment issue, or both?
That's a great question, and the answer is likely both. Um, we're still seeing, for example, CMS just released the 2022 QPP uh, experience report, and so there is some delay in the amount of time that the between the program and the analysis, but I think it will be very likely that it is shown both ways. And it is going to be also specific to organizations in particular.
Yeah, great. Um, let's see. I think that is actually, even though we've got a lot of folks, that may be the the last question that came in for now. So, but I'll tell you again, if you have a question that kind of comes to mind as we're just wrapping up, go ahead and submit that, and someone's going to reach out to you to answer that quickly. And thank you, Dave, for a fantastic presentation. This was great. You always do a great job with these pretty weedy subjects. As we wrap up, just wanted to encourage you all to head over to vbcexhibithall.com. There is a area where you can check out Roji's virtual exhibit booth, and there's a lot of really neat resources to see here. You can read up on what they're doing in the space, learn more about them, and of course, be able to reach out directly. And then finally, if you would like to reach out directly to Dave or to the team, feel free to do so. Their contact information is on the slide here. Dave or Leonard will be happy to help you. Or feel free to reach out to me too. I'm happy to facilitate an introduction. But thank you all again so much for joining us for today. Again, we're going to have 2 more sessions like this in the 3-part series. So in the thank you email that we send out, there's going to be a place where you can register for those as well. Or again, feel free, if you get confused, feel free to just reach out to me. I'm happy to steer you in the right direction. But thank you all again so much for joining us. Hope you have a wonderful rest of your afternoon. Thank you so much. Bye-bye.
Thank you.